This presentation will be looking at some of the more common pathologies affecting the vertebrobasilar system, particularly those that have most impact on our practice. Before we start, let's take a few moments to review the anatomy of the system. Identify the structures marked with an arrow. Partial answers are at the back, but only some of the solutions are correct. For example, one of the solutions is AC joint. This is unlikely to be a correct answer. The main intent of this presentation is to deal with traumatic vertebral artery problems, but non-traumatic causes must at least be touched on. Atherosclerosis, atheroma, osteophytic and even disc compression tend to occur in the older adult. In fact, atherosclerosis being the most common cause of non-traumatic VBI by far, occurs mostly in the aged population. None of these will really be associated with moderate or even severe neck pain. Bowhunter's syndrome is often associated with congenital anomaly of caliber, so that rotation, extension or rotation side flexion can cause dizziness. Subclavian still syndrome is where blood is taken from the VB system, usually due to a blockage proximal to the origin, and the patient complains of dizziness on using the left arm. Most of the work on cervical spine trauma and vertebral artery injury is revolved around those patients suffering fractures or dislocation, so few figures are available for those without obviously disruptive injuries. But the association with severe injury in VBI is high. Interestingly enough though, those suffering such injuries to the VB system that have symptoms is low. These pathologies are either the most common or the most relevant to us. The dissection is the most common injury to the artery and consists of a tear of the intima or media with subsequent bleeding, hematoma and thrombus formation. Usually the tear is subintimal, but occasionally subadventitial, in which case a pseudoaneurysm may form. A flap of the intima or the hematoma thrombus will cause various degrees of blockage, producing stenosis distal to the block and dilation downstream from it. The clinical consequences depend on the size of the blockage and the artery blocked. Another consequence of this lesion is that the blood flow is redirected from the lumen of the artery to a path between the intima and media, or the media and adventitia. If this occurs, oxygen cannot be absorbed and ischemia may occur, depending on collateral circulation. Embolus release is probably the worst consequence of this lesion, and its effects will depend on where the final resting place of the embolus is. There are at least three types of pseudoaneurysm. The ballooning out of the adventitia as a result of intramural tearing affecting the media, dissection of the artery with the blood being contained by the surrounding soft tissue and looking like a bulge, and a radiological artifact where a coil of one artery is seen behind another artery and so looks like an aneurysm. The true pseudoaneurysm forms after the intramural tear as the blood strips the media away from the adventitia. This in turn bulges. It may rupture spontaneously or with provocation such as movement, sneezing, range of motion testing or manual therapy, or it may stabilize and disappear. The previous slide depicted a true pseudoaneurysm. This slide is one of the type that is a bleed, but the blood is contained by surrounding soft tissue and so looks like an aneurysm. Transections of the artery are much less common than dissections, and this is where a tear is through the artery either partially or completely and will result in bleeding. If the injury is extracranial, the blood may do no damage whatsoever. On the other end, if it's intracranial, it may actually fill the cranium up with blood and produce pressure problems. These fistulae may be congenital or occur by known trauma or spontaneously, although that probably only means that the trauma has not been identified. As per usual, effects depend on the size of the malformation and its location. In the vertebral artery, the left is more commonly affected than the right, and this may be due to the presence of a bony anomaly over which, if present, the left artery runs. A thrombus will form if the artery is injured, but the size of the thrombus varies from very small to so large that it not only blocks the artery but also compresses surrounding structures. The effect of the embolus depends on which artery it blocks and whether there is collateral circulation present. So to come out of an embolotic event in decent shape, the other artery needs to be of normal size and the affected artery not a terminal one. There is no vertebral vein in the transverse portion of the system. Rather, the vein breaks down into a plexus that surrounds the artery. This means that if the vein and the artery are torn, they can form a fistula. In this case, the arterial blood may be pumped into the venous plexus, which becomes engorged and can in turn choke the artery. There is about a 20% frequency of vertebral artery injury associated with cervical fractures and dislocations. The most common associated fractures are burst, transverse process, particularly when the fracture extends through the transverse foramen, and unilateral fracture dislocation. Bilateral dislocation is less commonly causing VA injuries. Burst fractures are not an immediate concern to us because they are picked up at the time, but the others may have a delayed diagnosis. However, even if the orthopedic lesion is diagnosed, the VA lesion may not be. Only 15% of people with this fracture, when it extends into the transverse foramen, escape vertebral artery injury. So if this is found in the patient's subjective examination, take note of it. Also remember that only 20% or so of these patients would have symptoms of vertebral artery problems. A jumped or dislocated facet is almost invariably caused by a flexion injury, which results in the superior facet jumping over the inferior and causing the vertebra to lie anteriorly, narrowing the spinal canal and stretching the vertebral artery. X-rays are not very good at identifying this lesion, especially when it's unilateral, and this can be seen in the accompanying image. The CT scan, however, shows it well. In more than one study, cervical fractures and dislocations were associated with vertebral artery injuries, about 20% of the time. Flexion injuries much more commonly cause these lesions, and these were found to not resolve by themselves but needed interventions. On the other hand, extension injuries compressing the artery rapidly demonstrated recanalization of the artery within a short space of time, suggesting vasospasm and or minor injury. The answers to your anatomy review. Not all of the answers on the slide are correct. Select amongst them.